Yeah.
So this will be the first reading for the hospital budget.
All right, you ready, Craig?
It's your party now, at least for the next 60 minutes.
You can't have
Well, my watch says 6, so I'm going to go ahead and get this Finance Committee meeting started. So good evening. So tonight, we're going to be hitting the 2026 city appropriations budget. Even though I might be the Finance Committee Chair, I'm not going to pretend like this is my party whatsoever. So therefore, I'm going to kick it over to our Finance Director, Andre Dordia, and you can enlighten us on what 2026 is going to look like on the city's budget.
It's going to be beautiful. First person to present this evening will be our hospital CFO, Mr. Jason Rohr. So I would invite him to the podium or sit next to big, beautiful Phil.
Either one.
Wherever you'd like, wherever you're most comfortable doing.
You can spread out. Thank you, Andre. I assume everyone got the packet that was sent out?
Like 3 minutes ago, yes.
Okay.
That was me. I printed out the hard copies.
So this is on first reading.
Well, technically,
Can't have it on second reading.
technically the ordinance is on second reading.
It can't be second reading.
It is. Law Director?
And the last meeting, it was brought before you, and I told you it has to be on. One is, it may be a,
Why bother showing this all then?
bringing it before you, that's the purpose of it being there, and having been brought to council.
It
that
wasn't
would make
brought
that-
to council till today, so.
That was the last.
Those meetings
That's-
of the board are public too. You could attend those.
Our board of directors approved this on Wednesday. I mean,
Right.
I will defer to.
Let's go ahead and get
But
moving on
If I
it.
need to do anything, I will come back, so just let me know. Turning to page 1 of the packet, we'll walk through several portions of this, and again, please stop me, ask any questions as we walk through, but it's a very similar packet that I went through last year. The service and demand assumptions that we have shown on 2022 presented on the far left-hand side, the budget for 2026 on the far right. Starting off in row 1 with our acute inpatient admissions, we are projecting a 2.5% increase in inpatient rehab and transitional care, just slight increases. And a lot of this is really going to be driven by the ER visit volume on row 21, jumping down further in there. We're projecting 11.3% based on a lot of the information that we've reviewed, not only to kick off the project to actually build the ER itself, but they said in the year you open, and the increases that are seen are anywhere between 15 to 30%. One, because patients want to come, they want to see what that new ER is like. Usually once they see it, they say it to more people and more visits end up happening. So those higher visit counts can happen for at least the first year, could be 2 years. We're only projecting, as I mentioned, 11%. But if that happens, I will say that in 2025, we are continuing to see more and more sicker patients show up in our ER and then also get admitted up to the floors and stay overnight. So the acute admissions, as I talked about, at 2.5% in row 1, we are trying to stick to the math that we've used year over year. That's a tried and true method, that the more ER visits you have, as well as the more patients we see through the ER, then end up getting admitted to the floor. So following down in rows 6, 7, 8, the total patient days. Right now, on average, we're seeing most of those patients stay anywhere from as low as 2 days. It could be upwards of a couple weeks, but when you average all the numbers out, the average length of stay is about 3.2 days. Our total patient days on row 9 is projected to be 28,234. Our births are also in row 11 projected to increase. Within the births, we get sort of twofold of the days, one for the mom and one for the baby. So we keep track of both of those separately. We were fortunate enough to hire Dr. Kelly Van, who joined Bloomington Women's Care. She started November 1st. So just last month, we added another OB-GYN physician to the Bloomington Women's Care. And then we have another physician that will be joining us in September of 2026 as well. We still feel that there's a greater need to the community, but being able to secure at least this one in 2025 and another physician for 2026 really sets us up to take care of the births and the women in our community.
Excuse me, real quickly, just to
Yeah.
ask, or for clarification, you said that the woman and the baby are counted, that's just for the admission, not for the birth, right? That's just, it's one child, right?
It's one child for
Okay,
the
I gotcha.
birth.
But
and
when
then-
it comes
but
to
for the-
admissions, that's
For the
two.
admissions, we are able to count them twice because they're both admitted to the
Sure.
hospital. And then same thing follows through on the days count as well.
Okay, thank
But the
you.
birth is only for the baby.
Yep, okay.
Starting in row 17, 18, 19, and 20 is our surgical case volume. You'll see we break out both inpatient and outpatient. Outpatients are where a patient will come in on the same day and also go home that same day, or potentially stay less than 24 hours. So what do I mean by that? They could come in, have a surgery, but they leave prior to the 24-hour mark. So they could stay overnight, but only for that one night in an observation status. And when they do, that's considered an outpatient procedure and doesn't get categorized or charged as an inpatient procedure related to our surgery volume. We've been able to add several physicians underneath Bloomington, medical services, one related to Dr. Siska in plastic and reconstructive. We also have Dr. Dylan Childs, who'll be starting in February. They both do a lot of hand surgery cases, so we've seen greater volume related to our OR cases on the outpatient side. We've also, as I previously mentioned, talked about our home or ER visits. And then our outpatient registrations number in row 23 at 154,945. That's a 3.7 projected increase, but every other service line that we have would roll up underneath that row. So if you come in for just a lab test, you come in for an x-ray, you come in for a surgery as an outpatient, your registration falls into that line of our statistical summary here. One statistic that we really keep a close eye on is the adjusted patient days in row 24. We're projected to have just over 76,000 days on the budget of 2026. Now you may ask, well, why is the projected so high, and why are you budgeting 2026 to be so low? The adjusted patient days is different than what's in row 9, and that's because in row 9, it's every day that inpatient is in the hospital for 24 hours. The adjusted patient day is a calculation that takes into account your outpatient revenue and your inpatient revenue, trying to give the outpatient sector of your business how many days that would take to match up on an inpatient side. The acuity of an inpatient's obviously a lot more strenuous, higher staffing levels than an outpatient. And what I mean by that, someone that comes in for an x-ray or a lab test versus an inpatient that's sitting up on the floor in the ICU. Any questions on that top section at all? Yes?
You might not know this off the top of your head, but I'm just curious on the births breakout. Like, what are we talking births for City of Worcester residents versus county versus maybe outside of the area?
I don't know that I have that number broken out specifically, but again, this would be any patient that shows up at Worcester Community Hospital and gives birth. So right now, we know that there is not a maternity unit in Ashland or Medina. So any patient from those two areas could come to us and again, be in that statistic. We've definitely seen a change in our births number, but I would also say that, again, some of those births are being directed elsewhere based on either PCPs or who their provider is that's caring for them as well. But we have seen a greater impact just because of other institutions closing down those units. Any other questions on that piece? Next section down breaks down our FTEs. We are projected to be over 900 at 903. We, like I said, really try and manage our FTEs per adjusted patient day because we need to watch how many FTEs we have with the care for both inpatient and outpatient sector of the business. We're projected to be at 4.35. Currently, we're running at about 4.05 for 2025, but with the expected increased growth, both in the ER, EVS to clean the new ER, as well as just different service lines that we'll talk about on the next page related to our outpatient business, we've seen more and more growth that we need to have more people on site to treat and care for those patients. Specifically related to the ER that I've talked about several times, we are adding 5 FTEs, but even in those 5 FTEs, it's going to be about 12 to 15 people, just because we got to have enough for a 24-hour service in the ER itself. Any questions on page 1?
Yes.
Yeah.
Line 30, let me back up, line 28, 29, 30. Line
Yes.
28,
Line 28,
line 29, you're saying that at this point, there's what, a 1% increase for the salary increases? But yet I've got a 5 million. I've got a different number that in a copy that I get received previously. I'm saying that mine's showing all of 3%, this what we just got tonight saying all of 1%.
correct.
I'm trying to understand that, and then also the next line is, at 3%, the estimated year budget or impact was $1,046,700, and you're saying at 1% on the one that we received this evening is $1,047,306, or $1,047,396. So, I'm not trying to be a pain here, but I'm just trying to understand why I get the same sheet.
Nope,
two different
understandable.
numbers.
Yeah. So this page that's put together, everything's keyed in on it. So the original version that you had of a 3%,
Well, how can
and then
1% be less than, how can 3% be less than 1%?
from $1,000,
Whatever, just, I'm not gonna.
for $1,000,
It doesn't make any difference at this point, but that's fine. It's-
well, let me explain it just so you have my explanation. The 3% that was stated there was inaccurate. It should have only been 1%. So that's why we made that change. It was just a keyed in number 3 and we changed it to 1. So it should have been 1 from the get-go and I didn't catch that. So that's on me, but that's why it changed from 3 to 1. Now, as far as the $1,000 difference and change that it went from $1,046,000 to $1,047,047. And then also, I think there was a comment about it being $5 million on page, let me find it here just so I quote the right page. It's on both page 7 and page 4 at $5 million increase. What I'm showing in line 30 is the estimated budget impact of that 1% that we give to our employees related to our general wage increase. Now, the reason it originally said 3% at one point is because for every new employee that starts, through their performance evaluation, we give them a 2% increase. So 1 plus 2 makes the 3 that we had in there originally. Now, how do I go from 1 million on the front page of page 1 to 5 million on page 4? A lot of that is driven because the FTEs went from 886 to 903 to be able to care for all the patients related to the ER. Now, mainly in the ER, we have a lot of RNs. RNs cost us a lot more in a wage than, I'll admit, a registration person or even EVS person. So based on the amount of FTEs that we expect to have within the different roles and sectors or departments, that's what drives why I'm only showing 1 million on the front and 5.2 on the back, page 4 and 7. Any further questions?
I do have a further question on
Yes.
page 1. You are projecting a $9.3 million increase in income from operations. That is a massive increase. Can you kind of walk me through where you're going to increase to 9.3 million in income from operations?
Yes. I'm going to flip to page 2 for a minute and break down some of those. So within our inpatient business, it's at the top of page 2. You can see that, again, as I mentioned on the last page, because of the increase in ER visits, we're going to see more inpatients as well that we're going to have to care for. So on med-surg, ICU, women's pavilion related to the births, we're projecting in total 3.6 increase on patient days on the inpatient side. We're also expecting a 14% increase on inpatient surgeries. Why is that? It's because of the mix of inpatient cases we're doing related to, one as an example is Dr. Barry with our spine procedures. Those cases, as he continues to be ramped up, we've seen an increase in volume from him, is solely related to inpatient. So when 9 million seems like a large number, and I don't disagree with you that it's a large number, then I have to factor in all the outpatient growth, which is the bottom of page 2, driven largest by cardiovascular. We've added a general cardiologist to Bloomington, Dr. David Wells here, that started in October. He'll be able to do additional reads and studies on the outpatient side, which is then going to lead to more procedures in the cardiology department, which is why at 15%, that seems like a large number, but with the investments we've made to the physicians, the staff, and to care for the community, that's just one example. MRI, we installed a second MRI in 2025. Previously, 2024 and back, we only had one MRI. We noticed and brought in a mobile unit because we started to see wait times increase. We now have 2 full operational MRIs at the main campus, and with that, the new MRI is doing additional cardiac studies, and we've brought that wait time down from, I think, as long as 13 weeks back down to 2. So we're continuing to see more and more patients fill those slots, need those slots, and that's just the top 2 related on the outpatient sector side. So while 9 million, again, is a large number, there's all the volume and different sectors within the hospital, both inpatient and outpatient, that goes into supporting a lot of that. Is there any other specific area you'd like me to touch on? As I mentioned, 11% within the ER. The next several, we break out all the different modalities in radiology. We continue to see increases in bone density, PET scans, CAT scans, with the increase projected for both surgery, inpatient and outpatient. That leads to anesthesia, cath lab, and endo procedures that Dr. Friend and his department continue to do. Those are just the largest ones, going down through about 6%. After that, I would say they're fairly mild increases that we're projecting to finish out the rest of that page. Any questions on page 2? Because page 2, the volume is what leads to the revenue that we expect to have in 2026. Page 3 breaks down the actual P&L that shows what we budgeted 2025 to be, where we're projecting 2025 to end, and then the budget for 2026 as well. Last year, as well as this year as well, I think there was a question similar to what you asked, Michael, about the 9 million being a large number. While that is a large number for us, it's projected to be, what was it, I think, 5% on net revenue for us. And I think last year we had a question about the operating expenses increasing. And that was about, this year, we expect about a 3.5% increase on total operating expenses. But what is 3.5%? $6.6 million. So these are large numbers, no doubt about it. But it is only percentage increase that right now, I wish it'd be lower on the expense side. We're just not seeing that related to whether it be staffing, salaries, or having and continuing to offer services that we feel are important and needed in the community.
If I'm looking at it, though, your 2025 budget way overshot your income, though, and that's my concern about 2026. You overshot it by 5 million. Is there anything specific you've seen in 25, just something was just a miss, or something just broke down that that we can point to and say, man, we might have been closer to it, but something catastrophic happened, or it was just man, we just missed?
Yeah, one big miss for sure has been our cardiology and, cardiology as an example. Our cath procedures have been down, which is part of where, again, we were hopeful to bring Dr. Wells in. We got him now, which should help bring those numbers back up in line with where we need to be. But cardiology this year, honestly, is trending similar to 2021 and 2022. 23 and 24, great years for us. We use historical averages, so we expected 25 to be similar to the past 2 years. It's hard for me to tell when we're going to have that bad year in a service line. Surgeries, as an example, have been fairly strong, but I have not seen the growth either that I expected to have. We've been consistent, but not where I wanted to be. But we also had 2 plastic surgeons leave our organization that would primarily do surgeries. We've been able to recruit and bring new people in, but again, getting them up to speed and getting their panels filled is what our priority will be. Now that they're here, 26 will look different than what we did in 2025. Another example would be oncology. Oncology, we under budgeted for, and their volume has been doing great and continues to grow. So did I push their volume up in 26? I did, because 25 has been a better year for them. So I'm hoping that we continue to reach more patients and care for more in the oncology service line. Any other questions?
I mean, if you're a service business, so the wages and benefits total about $94 million.
Mhm.
That's what you guys do, is take care of people and keep.
We do. It's our greatest asset is our people. Without them, we can't do what we need to do. But those are very large numbers for us.
$104,000 average per person who works there.
Mhm. We spend over $525,000 a day. Yes. But we also wouldn't be able to take care of the community we have without them, so. Our claim expense for related to benefits has been a large we've been a high utilizer this year. Our own healthcare plan has been high in healthcare claim cost. And that's really what's hit us. Primarily, I think there were 2 or 3 large claimants that we had to incur those expenses, but we do see that changing, unfortunately, but from a budget standpoint, fortunately, in 2026. So,
Health insurance went down.
because those enrollees will be off our plan, so yeah, that's why we expect that to come back down in line with where we need it to be. One big topic that we talked about last year was in row 16, our fees for physician and other. I mentioned this in Q4. We had 3 hospital-based groups last year come to us and say, within 60 days, we will no longer be providing services. Those 3 services were pathology, anesthesia, and radiology. So what that meant, you can do all the x-rays and CTs and MRIs you want. There's no physician that's gonna read them and give the information back to anyone. Anesthesia, there's nobody to put you to sleep. And pathology, there's nobody to read the lab specimens. So we found new vendors. We've made it, I would say, across the bridge at this point in 2025, but they've what led to our projected expenses being higher than we budgeted. Why? They've had to bring on additional locum staff to help support the volume that we have. One example being the radiology group. They knew it was Wooster, Ohio. They knew it was Wooster Community Hospital, but they said, you're a very unique community hospital. The amount of tests you do, the type of tests you do, the forefront technology you use, we don't see that in a community hospital that's taking care of a community. So it's great, but we have to support you. And it costs us more, so I hate to say it, it now costs you more. So we're seeing that flow through that physician and other fee line. We, like I said, made it successful transitions to OSU for pathology, Northern Light for radiology services, and anesthesia we actually brought in through Bloomington Medical Services and added that as a new service line under Bloomington. By the end of 2025, Bloomington Medical Services will be up to 28 different service lines that we offer within our affiliate company that ultimately goes and helps drive everything we do in the hospital. Without Bloomington, all these numbers from revenue to expenses, even though in the operating section it's primarily the hospital, we would not have the volume and services that we have. Roughly about 60% of the volume is driven or signed for by a Bloomington physician itself. So, very much need Bloomington, and that's what's able to help provide the care and support that we need. Any questions on page 3?
Are all their numbers incorporated into these numbers?
No, so Bloomington has its own budget, separate board, separate approval process. The volume that they bring and drive to the hospital is in these numbers, but only the hospital side for Bloomington. I just mentioned the physicians and everything, because without them, the volume here wouldn't, and the numbers wouldn't be as large as they are.
I have probably an ignorant question, so blow me off if you're like, what is she talking about? But is there any world where it's possible that like, you're talking about like radiology and pathology and the people that read those results, is there any world that we can do that in-house? Because we're proud to be able to offer a lot of these services in-house, but we're shopping around and paying probably top dollar for a third party. I get crazy bills from these, agencies for radiology or for whatever. It's very confusing. It'd be great if we could do it all in-house ourselves.
We've posted as soon as we got those 60-day notices, and I think we've been able to hire one physician assistant for radiology. We've had several interviews, but unfortunately have not been able to bring anything except for anesthesia.
Okay.
Anesthesia, as I mentioned, we brought into Bloomington, but even there, we've seen additional locum expense because not everyone wanted to come across. I just read an article in Becker's today that said by 2030, we're gonna be short like 6,000 anesthesiologists. We're already feeling it today, which is part of the issue. I'd love to bring them in-house, because you're correct, it would be cheaper. But finding them is the issue. But I will say, as with anything, we're trying to figure out how we can reduce costs. So I don't have anything signed today, but it's something we are definitely working towards and having conversations on. So, yes, it is very expensive, any physician is, but ultimately, yes, if we could do that versus having a locum, we would. Other questions? Page 4 breaks down a little bit further from the P&L that you just saw on page 3. All the expenses by categories, shows the projected and the budget. As we talked about, the 5 million is a large number. That's 8.2% increase from where we're expected to be in 25, but that's primarily driven, as I mentioned, from the ER. 5 FTEs relates to about 12 nurses. I have 1 FTE that I feel we'll need for EVS to clean it, but that wage is drastically different than the 15 nurses I'll have to hire. As related to, as we mentioned, MRI. We brought the second MRI on. I've needed additional MRI technologists to support the volume and support that. Well, that flows through and shows in our salaries. But while salaries is going up 5, the revenue we've also accounted for in the top of the P&L to offset that expense increase itself. I'll pause and see if there's any further questions. On page 4 or 5, you also have detailed explanations on 6, 7, and 8, I believe. I want to be mindful of time for Andre allowing me to come, just to leave myself a couple minutes to talk through some capital expenditures for next year that start on page 17, but I'll pause as I mentioned.
We are at 30 minutes. Go ahead.
Okay. So starting on page 17, we have our 2025 carryover projects. These are projects that we have started but haven't issued all the POs for. So our board had approved, as an example, the elevator 5 modification, but we haven't issued the PO because it hasn't went out to bid yet. That should happen by year end, but that's a carryover project in 2026. Same thing related to what falls under strategic facility plan for the Patient Access and Emergency Center, completing that project here. The keys will be turned over to us in January. We'll go in and install the rest of our equipment for the ER, and then it'll be operational by the end of February with open houses, 12th, 13th, and 14th, as well as tours on Thursday for all of you that we emailed about. Turning to page 19, we again continue to try and invest in our information systems related to security. While these numbers don't reach large numbers, I just want to call out that, again, we do everything we can, and I think we do more than some institutions that I've been at, just trying to keep all the information as protected as we possibly can, because we know that PHI is very, very important. It needs to be held to that highest level. Last comment, under plan operations, we're planning several renovation projects. Some of this is related to our facilities, but also expanded facilities, whether that be up at Milltown Professional Building, Health Point, or the main campus itself. And with that, those are my big notes that I wanted to just highlight on the capital portions, but happy to answer any other further questions that you have.
What is Milltown White Box 16?
So that's at our Milltown Professional Building. We're planning to do a build out there
Oh, okay.
with one of the tenants.
Any further questions for the hospital?
And I will offer, if you have further questions, get them to Andre. I'll give you my information because I have the email that Megan sent out today, I believe, with the ED tours. I can respond and get you my information. I'd be happy to answer any questions that you have as you do work through the packet.
I would recommend being at the next board, or next council meeting as well.
I can do that.
That'll put it on the final reading.
Okay.
Okay. Andre?
Very good. Thanks, Jason.
Yep.
Good job.
Absolutely.
You do. All right. There's a couple, I don't know, not really housekeeping items, but there's, I think, about 5 small little new items I've added this year. Every year I try to add something new, but one of the things we did add this year is a comprehensive table of contents. We normally just had a table of contents for just the section 2 only, appropriations budget. This is for the entire document. We also added a statistics page on 1-7. We also added kind of a neat thing called relationship between funds and city departments. So there's like 40 funds, and you can cross-reference on page 1-37. It's a nice little quote out. You can see, for example, police, what funds, or safety, what funds affect those. It's kind of, or police, I'm sorry. On the back of that, there's just some charts and graphs, and then one of the also items we did, we always had items that were cut from capital, but it was kind of, I don't want to say hidden, but it was in one of the other sections. Not really easy to find, but I wanted it to be easy to find for you to say, hey, what'd you cut from the budget? Well, so we put that at its own page. It's 3-11 would be the new item there, the cut items. Just hopefully makes things easier to understand and see. Since we do have a couple new council members, I just quickly would want to reiterate that this budget book is divided into 7 sections. Your first section, obviously section 1, is an introduction section that includes city officials, the core values, an org chart, also staffing levels, and then very important is all the department narratives that are included in there. Section 2 is the meat of the budget, that is the appropriations budget. And section 3 is our capital budget. You'll see each capital or infrastructure item. Section 4 is our future planning for capital and infrastructure, very important as well. And then section 5, Jason just went over with you, is the Worcester Community Hospital budget. In section 6, I include some outstanding debt information. For, I think, 5 years, I do that there. And then section 7 is a glossary of common budget and municipal finance terms, because there is some goofy nomenclature with respect to, I guess, our budget nomenclature. Anyway, so with that being said, first thing we typically cover would be the page 1-6. I'll let Joel handle that. That's the staffing issues. We talked about staffing, and Joel may have some highlights with respect to page 1-6, which is staffing. Joel?
Just one thing I wanted to point out is, we have several retirements coming up this year, and so there are some, for succession planning, we have people that we're adding to have some overlap, so it'll be a little heavy this year, but that'll go away in 2027, once those people retire. So we've got a couple of captains in the police, where we're gonna have some overlap for a good bit of the year, and then some will retire. We have a position in fire that's gonna be, we have some overlap there, and will be retiring. So I just wanted to point out, it was a little bit heavy, but some of those will go away. We did add 2 40-hour week firefighter positions to cover those peak hours, because that's when our peak. So the hope is we can cover those peak in operations. They won't be 24 hours. Those be, I'm not sure if they're going to be 8 or 10-hour shifts, but 40-hour week shifts. Hopefully help us with the overtime there as well. I think those are the big, just the big changes. And just another thing to point out, FTEs, full-time equivalents. That's not actual full-time people here, so, and we have a lot of seasonal part-time that are in that number as well. And the last thing is, we always budget as if we're 100% full, and that's never the case. So we budget for 100%, but that's almost never the case. We always have, a handful at least of positions that are vacant at any time, and we just keep it normal. I think we're like 209, 211 right now, actually.
Yeah, for full-timers?
Yep.
Anything else?
I did include in section 110, in the narrative, just a little bit of a history of our full-time people. It's interesting when you go back and look at 74 and 94, we were about the same at full-time that we are now, a little bit more now, which should be expected of just like what we're doing.
Joel, what would the transportation services positions have been prior to 124, before we had our own in-house transportation department?
Yeah, we've had transportation for those services before we had an actual transportation program. And
So, yeah, those relate to streets, roads, and our traffic signals, that kind of stuff. There's based on our street. The old East Coast Street Department,
Okay.
so part of our maintenance for roads,
some
roadway
of
maintenance.
the people,
Yeah.
or part of their time.
But then our transportation department is now grouped in categories with that,
That would be one person, yeah.
just Kevin?
Kevin,
Yeah, okay.
Yeah, you done?
Back to you.
Okay, so anyway, the other thing I always want to cover and point out is, real quickly, it's page 1-36. So a lot of you may or may not remember, but back in 2014, when we had some revenue issues, we went to the voters and said, hey, if you approve this tax increase of 0.5%, we will utilize half of the funds. We're estimating we'll get $5 million from that 0.5%. We'll use half of those funds for capital and half for operations. So that was a promise made to the voters. So what I always try to do is, there's nothing worse than a public official or a politician making a promise and not upholding that promise. So I always have this little chart here to show what we've spent in the general fund toward capital infrastructure. And you'll see the average from 22 to 26, what's budgeted is probably $5.3 million there. So that's just showing that we have upheld that promise. And that's it. I think it's very important to let the voters and you obviously know that we held true to that. So that's the only reason why I show that. So I don't know, if there are any questions regarding any of those two items that we just discussed. If not, I would like to move on to section 2. Specifically, just a reminder, so if you see pages 2-2 and 2-3, interestingly enough, this is the one, these 2 pages I send to our county budget commission. So out of this whole giant book, that's what goes to them. And it's basically for the prime purpose of showing, hey, you're not spending more than what you're bringing in. That's the sole purpose pretty much of that. But that's just a part of the budget document that's there, and just wanted to point that out. Next thing I would like to go to is our general fund, which is on 2-6 and 2-7 specifically. I'd like to take a quick look at the top of the page under the 2025 forecast versus the 2025 budget. And I know this is obvious, but I just also want to point out that the general fund is our main operating fund, and it's basically tax-supported government entities. So any lawful municipal purpose can be spent out of here. So let's take a look. So overall, we had a little bit of a down year. Our revenues are going to be about $600,000, 1.6% under what I had forecast. Primary reason for that is we had 2 record income tax years, 23 and 24, and so those backed off a little bit this year to the tune of probably 6%, or about almost $1.8 million. So that hurt us there a little bit. On the other side, if you look at, let's see, what was I going to say here? I actually have some notes. Okay. Oh, I did want to also mention, yes, since 2015, so we've actually had, if you look at 2015, I check all this crazy stuff, we've had an average favorable variance of about 6.5% to the good. However, I always like to be a realist, and I try to scrub out any anomalies. So if you scrub out the 2 crazy good years, and you scrub out the two COVID years, because that was wacky too, we're still at about $800,000 or 3.2% favorable revenue variance. As Abernathy might say, maybe I'm sandbagging, but I'm just being conservative in my revenue projections. So. But to the tune of about 3%, if you look at the averages out. Also, something interesting, so I think we've got our tax in place for 57 years. In those 57 years, we've only had 10 down years. Next year, you know, actually taxes receipts going down. So 1 in every 6 years, we'll see that, and we just saw it this year. So that's that side. Now, on the good news is, if you look at the expenditure side, you see that we're gonna finish about 3%, 3.6% under budget, or about 1.4 million to the good. And again, I don't know if some of you that have been here for a while know that that happens pretty much every year. As a matter of fact, if you, again, stripping out anomalies, COVIDs, because that was a crazy time, we're still average about 5.6 million, I'm sorry, 5.6% favorable budget variance every year average, which is the tune of like $1.5 to $1.8 million. So, and that's bar none. And part of that is because of our budgeting process. We're budgeting 100%, you know, staff positions, so there's contractual obligations we're budgeting for. There's also things such as we have deductibles on our liability insurance. We budget for that because you know, it's 25 grand a pop. So there's those sort of things that you budget for, and then we also budget for what are called our compensated absences. So for example, if we have somebody that's retiring, we don't just, it's not just a surprise to say, well, we're gonna find this money because they get, you know, paid, say, whatever the contract says about it, they get some sick leave or whatever that is. So actually, it's just being responsible budgeting. So that's that part there. So, but you will also see, so if you look at the forecast, You see that our revenues, they're almost 34.8 million. We're gonna spend on operating 31.5. That means we got about 3.4 million in excess revenue, right? However, below that, you're gonna see we're gonna transfer 5.125 million out. So where's that gonna go? Well, 4.7 million of that is going to capital projects. 425,000 will go to our transportation program, and that transportation program, Joel, expenditure last year was about 500, right? So we stayed about 100 at least? Yeah, so, I wanted to point that out. The other thing I did want to point out is, if you recall, 665,000 that transfer that went for capital will be paid back from the Silver Road TIF over the next 3 to 4 years. And I see it's going great guns. I just drove by there, I couldn't believe it. Anyway, so that's exciting. So basically, if you look at this, what this tells us is that, guess what? We have a net $1.7 million negative change in fund balance. We're basically using our, quote, days in cash to fund these capital projects. And so with that, our days in cash will end the year at approximately 237 days, or 3 days under what would be considered the upper limit of the ordinances. The ordinance says 240, upper 60 lower. Anyway, so there's that number there. That's important to point out. What else did I want to point out? It's still, it's very healthy, obviously. That's a very healthy level, 237 days of cash. Any questions on the forecast and how we compare the budget, how we budgeted? Seeing none, I would love to go to the next page and go to the 2026 budget, and then we have forecasted 27 through 30. So, the big number in our revenue section is obviously income taxes. So what I budgeted for a 3% income tax increase for 2026, okay? Now, if you look back, I like to look at all kinds of historical numbers, and I do this often, so forgive me for this, but you're gonna hear this number a lot. But if you look at our compounded annual growth rate, or our CAGR for you young people, it's 4.9% since 2015. And I only use that number because that's when our income tax was in effect. That's why I don't use prior numbers. But that's a 4.9% compound annual growth rate in income taxes. So yes, I'm not using the average, but I'm close to the average at 3%. That being all told, revenue projections are about a little over $545,000 next year to increase. If you look at our comprehensive annual growth rate of all our revenues from 2015, it's about 4.3%. So I'm forecasting about half, or less than half that at 1.6%. So we'll go down to the next section, obviously, and then we'll also talk more about, I include in your book a page that includes basically reasons for increases or decreases from the prior year. Well, Joel and I will go over that at some point, maybe not tonight, but at the next meeting or whatever. So anyway, but I want to go over the expenditure. So on the expenditure side, like I said, we always budget for all contingencies. That is about 2.172 million more than what's forecast for this year, or 5.9%. Interestingly, if you look at our general fund expenditures compound annual growth rate, it's about 4.6%. So we're at the actual. So again, we will come in obviously lower than that, as we do every year. The other thing is if you look at my forecast, I'm forecasting our revenues. I'm assuming a 2.5% compounded annual growth rate on those, which is a conservative lower figure, because part of the rationale of that is we don't know what's going to happen with respect to any kind of property tax, legislation, changes, et cetera, et cetera. And the other thing is, I also, my expenditures, I used a 3% compounded annual growth rate, which, you know, kind of commensurate with what potentially is gonna happen with inflation, or what's projected to do with inflation. So I thought those were decent numbers, but if, all being told, that would be, what I would consider a worst-case scenario going forward. And below there, you can see the numbers. So when I say the numbers, I'm talking about days in cash. You see 2026, if we would spend 100% of what we budget, and we would receive 100% of what I project in revenues, we would have 192 days of cash, and you can see that what those numbers would be going forward based on the 2.5% compounded annual growth rate in revenues and 3% compounded annual growth rate in expenses. The other thing I do want to point out is I do have in the transfer line item, which is toward three-quarters of the way down the page, in the brackets, the minus number there. I'm assuming $4 million going to the capital fund, and then I'm assuming $300,000 going to our transportation fund to fund our portion, you know, of the transportation costs. So, again, those are just, estimates on my part. And Jill, is there anything else you wanted to add that I may or may not have missed on my? I did want to say we would go with reconciliation sheets, so we do have 10 minutes. We can do that. You want to do that? Okay. So, as the hospital, as Jason mentioned, we had a record, unfortunately, a record bad year in medical claims. So we pay approximately $6 million a year for our health insurance. We had 7 claims over $7 million. So we're getting hit pretty good next year. So we're added to this general fund expenditure is $1.3 million for next year. That's on that separate sheet that I included in your in your budget. The other thing, obviously, is there's increases due to contractual wage increases, and then we budget, again, all positions, and then we have, in addition, several positions that Joel mentioned are gonna overlap. I know there's at least two in police, there's 1 in fire. I think what else? Anyway, so there's gonna be about $1.4 million increase in cost because of that. And again, I shouldn't say cost, I'm talking about added to the budget, because some of those positions, again, will not be filled the entire year. Some of them will be, you know, it depends on the hiring process. Anyway, so the other thing is there's $824,000 that we are reducing on the transfers out. And that's because of, we have $665,000 that we aren't transferring to capital that we did this year for the Silver Road. And then I reduced the amount of the transfer to our transportation fund by $125,000. So that's that number there. And then, so our O&M and capital kind of flipped, so in other words, we added to O&M costs by $799,000, so some of that's inflation, but then we also reduced our capital in the general fund by $529,000, and because starting in 2026, we had developed some extra best practices with respect to our depreciation schedules and what we capitalize. So instead of capitalizing a $10,000 road, we're gonna raise that level. Instead of capitalizing a $10,000 vehicle, that levels. So we actually categorize our vehicles to sort of be with our folks in the private sector, even though we do see no taxable benefit because we don't pay taxes from the depreciation schedules. But it does impact how the numbers show. Just like years ago, we used to have higher charity care in the hospital side. Now, because of the changes in the healthcare laws, we now have higher write-offs. So it's sort of like the switch. Anyway.
I can just add a couple of things. The other thing on the capital versus O&M side, and you'll see this if you go back and look at the capital paving for PPM, so maintenance, they'll pave smaller streets, alleys, and things like that that were typically, you know, around or under that $75,000 mark. go back there and you look, you'll see only 2 streets for PPM. Those are the ones that are over 75,000. They still have several streets they're doing, but since we bumped up that 75, so these are in like the 50 to 75 range, those are in O&M. So you see a little bit of increase in O&M, it's still the same work, we're just categorizing as O&M as opposed to capital because of that change. The one other thing I mentioned, I did mention that we added 2 new 40-hour-a-week firefighters, but we're also getting opioid funds. I think we're north of 600,000 we've received so far, and I think we've estimated through 2038, we're probably gonna be pushing 2 million or so in those funds. Different settlements come in at different times, some paid up front, some will come in over the time frame. So we think, we can probably utilize most of those to pay for a bulk of the positions that have to do with drug-related opioid type of things, so that'll be an offset to
Yeah.
expenses that we didn't really show here, but we'll probably apply that. You'll see it probably next year as we, adjust it.
Right, and that'll be based on the requirements of what those dollars can be spent on. And the opioid fund, just for your reference, is, it's fund number 126, it's on pages 240 and 241. You want to write that down and take a look at that. But anyway, so we're looking at about $2.22 million increase from the prior year from the budget side. And then including in this reconciliation page is water and sewer, which obviously we'll cover at another time. But are there any questions with respect to the 2026 or even the 27 to 2030 forecast going forward at this time? And again, we're always available, as I think you all well know. We're more than happy to meet and talk. And then I just wanted to point out that on pages 28 and 29, you'll see these numbers. So for the safety services, you'll see personal services, O&M, capital, debt service. Those are all numbers that flow to the prior 2 pages. So then you can look there to see what the budget is for those expenditure categories. And then we do have a couple minutes. I would just also point out that we do have pages 211 through 249 are something called our special revenue funds. These are revenues normally from a specific I'll just call resources, and then the use of these are restricted. For example, just to reiterate, some people are new, so I don't want to, I'm not speaking, I don't want to speak down, but like gas taxes, we get the gas taxes, so those are in separate funds, only to be used for street maintenance and repair and construction. Opioid funds can be used for specific
Basically, what's in the
expenses, right, relating to fighting opioid and that kind of stuff. So, and we have a lot of those. And so when I say a lot of those special revenue funds, as you will see, and a lot of those are also grant funds or also court-related funds you see that we get from Wayne County courts. A lot of those, the police funds can be used for that. And we budget typically almost all of those funds to be available, and whenever we find uses to save the general fund money, we try to use those first. So, and that's why, again, you'll see the general fund come in every year, well under budget, 4 or 5%. So, but that's, very important. But again, those special revenue funds.
All right, Mr. Dory, you feeling pretty good is a good place to stop?
Yeah, that'd be great. And then, like I said, if you have any questions with respect to what you heard tonight, feel free to call, email me or Joel.
Council, do you feel like we should go ahead and have another Finance Committee meeting before the next meeting, or? Okay. Well, then I will go ahead and schedule 6 o'clock before our next council meeting. So with that, we're a minute shy of 7 o'clock. We'll go ahead and call an end to this Finance Committee meeting. Thank you.